Good afternoon and welcome everyone to Bamboo Health's May webinar. Thank you for joining us. I am Allison Matheson, Senior Communications Manager at Bamboo Health, and I'll be kicking things off for us today. First, just a few housekeeping items. Participants are muted, but you can put questions in the chat. We'll be monitoring them and we'll present them to our presenter at the end of the webinar. And if you have any questions beyond what's covered, you're welcome to email solutions@bamboohealth.com and someone will follow up with you in the very near future. So Bamboo Health provides one of the largest, most diverse care collaboration networks in the country. Our network enables providers to improve whole person care with a full view of their patient, including physical and behavioral health, all within the clinical workflow. The goal is to improve health outcomes and provide more efficient and effective use of resources. Our vision is to revolutionize care collaboration for the improvement of whole person care, and we're happy to have you here with us today. Today, the focus of our webinar is on the new Accountable Care Organization REACH model. Centers for Medicare and Medicaid Services is replacing the Global and Professional Direct Contracting, or GPDC model, with the redesigned ACO Realizing Equity, Access, and Community Health, or REACH model, intended to improve care coordination and outcomes for Medicare patients, especially those in underserved areas. Here to help us sort through the changes and what they may mean for your organizations or those you work with is Molly Kane, Manager of Government Affairs and Strategy for Bamboo Health. Prior to her time at Bamboo Health, Molly worked in payer policy at Athena Health, where she led regulatory review of CMS proposed and final rules and coordinated Athena's operational response to payer and industry changes. Molly holds a degree in government and legal studies from Bowdoin College. While Molly is presenting, feel free to type in your questions and I'll hop back on after her presentation so we can address them. Molly, thanks for joining us, and I will let you take it from here. Let me change so that you can advance your slides.
Awesome. Thank you, Allison. All right. And thank you and hello to all of our attendees today. So as Allison alluded to, the goals for today's webinar will be to review the recently announced ACO REACH model that CMS unveiled towards the end of February. And we'll go over its incentives, its requirements, particularly how it compares to direct contracting. And then from there, we will discuss the concept of actionable interoperability, including what it means, how it can be achieved, and why it matters, particularly with respect to effective care coordination. All right, so now with that, let's jump into the content. So what is new for value-based care in 2022, and even as crazy as it sounds, as we look ahead to 2023? So while we, of course, are living in an ever-changing healthcare ecosystem, one particular change of note is the shift from the global and provider direct contracting model, or direct contracting for short, to the ACO Realizing Equity, Access, and Community Health model, or ACO REACH. So now just stepping back for a moment, direct contracting was introduced in 2021, so last year, joining the Medicare Shared Savings Program, or MSSP, and the next-gen ACO model in the high-risk value-based care space. That being said, shortly after direct contracting was announced, CMS did end up phasing out the next-gen ACO model, with it closing out at the end of 2021, leaving MSSP and direct contracting as the two options for organizations who are looking to participate in high-risk value-based care models. Direct contracting itself ended up being met during the first year with mixed feedback, and ACO REACH can really be viewed as CMS's response to this feedback, with the direct contracting model ultimately shifting into this newly announced ACO REACH model. And now just looking at the bottom of this slide here, there are a few key dates just to highlight. So the model will begin on January 1st, 2023, with it running for 4 performance years. So performance years 2023 through performance year 2026. And the application period for the model ran from March 7th through April 22nd, with applications now closed and awaiting decisions from CMS. Accepted applicants, once we find out who those are, will have the opportunity to participate in an implementation period from August 1st of this year through December 31st, although that is not required to participate in the model. But all prospective participants, including any current direct contracting participants, must meet the model's requirements by January 1st of next year in order to participate. All right, so now that we've discussed some of the high-level basics of the switch to ACO REACH, let's get in a bit more into why CMS moved to this model and how it will be different from direct contracting. So CMS designed this model with the hopes of using ACO REACH really to inform future innovations and updates to value-based care, including potentially using it to inform any future updates to MSSP and other ACO models. And the program builds upon some of the same key goals and learnings of direct contracting, and ultimately focuses on advancing health equity to bring benefits of accountable care to underserved communities, promoting provider leadership and governance to continue the momentum of provider-led organizations participating in risk models, and protecting beneficiaries in the model through enhanced participant vetting, monitoring, and transparency. All right, so to dive in a bit more into the ACO REACH model itself, so who can participate? And as with direct contracting, the ACO REACH model offers 3 different types of participants: standard, new entrant, and high needs population ACOs. So just running through them one by one. So on the standard ACO side, these will be entities that have substantial experience serving original Medicare members, including Medicare only and dual eligible beneficiaries who are aligned to an ACO through either voluntary or claims-based alignment. And these organizations may have gained their experience through participation in shared savings models or within the MSSP program, or they potentially could be new organizations that are actually composed of existing original Medicare providers and suppliers. So really meant to focus in on the organizations that have a lot of care already working in the traditional Medicare space. Now taking a look at new entrant ACOs, these are going to be organizations or entities that have not traditionally served original Medicare members. And these organizations will likely rely on voluntary alignment during the first few years for their populations with limited claims-based attribution. So really thinking through newer organizations or even organizations that are maybe well established, but in different spaces and in different lines of business. And then finally, taking a look at high needs population ACOs. These are going to be entities that have a lot of experience in serving original Medicare patients, particularly those with complex needs, including dual eligible members. And members for these ACOs will be attributed to the ACO through voluntary or claims-based alignment. And these organizations are truly expected to employ care models that are tailored to complex needs patients. So you can think of things such as PACE programs or other programs that are really meant to serve those highly complex patient populations. And then kind of moving to the bottom of the screen now. So within each of these participant types, there will be 2 different risk options, just like direct contracting. So we have professional and global. And within each of these options, participating providers accept Medicare claims reductions and agree to receive at least some of their compensation from their ACO. So taking a look at the 2 options, the professional option is what we'd consider a lower risk sharing arrangement. So this is 50% shared savings and losses with 1 payment option for participants, which is primary care capitation payment. And what primary care capitation payment really is a risk-adjusted monthly payment for primary care services provided by an ACO's providers. Now, on the other side, we have global. And so the global track is a higher risk sharing agreement where there is 100% shared savings and losses. And this global track has two different payment options available. So similar to the professional track, it has the primary care capitation payment, but then it also has total care capitation payments, which are a risk-adjusted monthly payment for all covered services, including specialty care that are provided through the ACO's participating providers. All right, so now that we have a sense of what types of participant tracks are available under ACO REACH, what are some of the key updates to the model, particularly when we're comparing it to direct contracting? So the ACO REACH model underscores the current administration's focus on health equity and moving towards increasingly provider-centric organizations and models. And based on this, CMS has introduced some key updates to the model with several categories of note that you can see here on the screen. So just running through them quickly, starting with healthcare equity or health equity. And so the ACO REACH model includes a benchmark adjustment to better support care delivery and coordination for patients in underserved communities. Also, each participating organization will be required to have a health equity plan, and this plan must include the identification of health disparities and specific actions intended to mitigate the health disparities that the ACO or organization has identified. CMS will also identify underserved beneficiaries using a composite measure that incorporates a combination of area deprivation index and dual Medicaid status to be able to really kind of center in and focus in on some of those underserved populations. Now, on the governance side, one of the kind of notable changes from direct contracting is that with ACO REACH, at least 75% of each ACO's governing body must be held by participant providers or their designated representatives. And this really is meant to ensure that participating ACOs operate as provider-led organizations. Previously, under direct contracting, providers only needed to account for 25% of an ACO's governing body. So this really is indicative of CMS's focus on ensuring value-based care and risk-sharing models truly are focused on the providers that are ultimately responsible for patient care and outcomes. On the discounts and quality withhold side, so in response to feedback from provider stakeholders, CMS reduced the discount in the ACO REACH model to range from 2% to 3.5% over the duration of the model, and this is compared to direct contracting, where it topped out at 5%. And CMS also reduced the quality withhold to 2% for performance years 2023 through 2026, compared again with a 5% quality withhold in direct contracting for those same years. And finally, just a quick note on the risk adjustment side. So for the ACO REACH model, CMS has adopted a static reference year population for the remainder of the model performance period. And CMS has also capped the ACO REACH's risk score growth relative to the demographic risk score growth. So the cap is appropriately adjusted based on demographic changes in the underlying population over time. Awesome. So with just 7 months to go before the beginning of the ACO REACH model for performance year 2023, what should organizations be focusing on to prepare for success? And one of the key considerations in striving for success really is to ensure that your organization implements scalable and broadly applicable strategies that will prepare you for success not only in ACO REACH, but really in any future changes to value-based care models as the industry continues to evolve. And these core strategies really come down to two buckets: maximizing revenue and maximizing shared savings. On the maximizing revenue side, organizations should focus on beneficiary engagement tactics that support retention, as well as processes to support maximizing quality scores. And on the maximizing shared savings side, organizations should think through implementing care management resources and processes that minimize avoidable utilization, as well as beneficiary engagement tactics that support proactive preventative care. Now, for all of these strategies, an important component for success is the availability of timely, actionable insights on patients delivered in a meaningful way to these care organizations. And so really, as we think about how these can be delivered to organizations in the most effective way to improve care quality, reduce the total cost of care, minimize post-acute spend, and manage utilization, including emergency department visits for patient populations, it really becomes clear that there's a ton of need and value for timely and actionable information, and ensuring that that information actually gets to the correct people that can act on patient care. So with that in mind, as we think about success in ACO REACH and really more broadly in value-based care models overall, it is important to consider how this timely, actionable information plays a role within each organization's success and better enables providers to make decisions for and with their patients based on multiple factors, even including things like social determinants of health and behavioral health care elements. Now, in a world where patients are seeking care across a variety of settings and organizations, and with each of these organizations maintaining their own separate systems, access to information on patients is incredibly dependent on interoperability. And as we all know, there's been a major push for interoperability, particularly over the last 10 years, and we really have made huge strides. But that being said, we are now at a point where the focus needs to shift just from interoperability in general to interoperability that actually delivers value for patients and providers. And at Bamboo Health, we like to call this shift the shift from foundational interoperability to actionable interoperability, with foundational interoperability being the base upon which all interoperability depends. But at the end of the day, this isn't where providers are ultimately going to see value. So you can think of foundational interoperability as things such as data quality, data standards, exchange protocols, and privacy, security, and compliance requirements. And then on the right-hand side here, you can see that actionable interoperability, on the other hand, is the point at which interoperability actually delivers meaningful support for providers and their patients. And so taking a look at some of the items that we bucket within this actionable interoperability category, we have process automation. So does data exchange actually drive task completion? Activity triggers. Does the data exchange drive the right clinical or administrative action? Cognitive context. Is the right data delivered where it can actually be acted upon? And then temporal context. So is the data available to the right person where it can be acted on? And now just double clicking into actionable interoperability, how does it truly impact patient outcomes and the provider experience? So if we think through the 4 cornerstones of actionable interoperability that we just reviewed on the last slide, these items in turn should ideally build upon foundational interoperability. They should leverage real-time data to surface clinical and contextual information, and they should deliver decision-ready analytics within a provider's workflows. And finally, it should account for patient preferences. So at the end of the day, this means that in practice, providers are able to collaborate with their peers and their patients more seamlessly, resulting in an increase in the closure of gaps in care, the improvement of patient health, and the reduction in the overall total cost of care. So now to contextualize this with an actual example, so let's walk through an emergency department patient use case today versus ideally where we will be at in the future. So at a base level of, a simple moment where a patient presents to an emergency department and then is treated and ultimately discharged there, at the point of their discharge, if the patient follows up with their PCP, treatment information will become available to that provider. And in some cases, the emergency department themselves will proactively send information to the PCP, but not always. And even if they do, it's not always going to be complete or appropriately contextualized. So now taking a look at kind of where we are somewhat today. So interoperability, sophistication, and utility has grown. And now looking at that same flow of events of a patient presenting to an ED and then ultimately discharging, hopefully now a care manager, either from the payer or a provider organization, is notified of that ED visit, and some actionable information is ideally passed along to that provider. That being said, the information shared is still not going to necessarily be standardized, not always going to be timely, and even if it does occur, it might not be the most useful information that that care manager needs to help coordinate the patient's follow-ups and other care. So now taking a look at the same model, but where we ideally should be. So with ACO REACH and other value-based care models, we are incentivized to contextualize the patient experience even more and account for things such as food insecurity, transportation, and other social determinants of health factors. And this means that information, analytics, risk scores, open care gaps, and other information is able to provide additional context to all parties that need to take care or take part in the support of a patient. That being said, it still isn't quite enough. And where we really should be is a place where additional players within the healthcare community are able to help close the loop between those care managers and the PCPs. So ideally, interoperability would result in solutions that provide discrete directions and activity prompts specific to that patient at that moment in time. And these solutions should also automate mundane activities wherever possible to allow providers to focus on patient care and ensure consistent information is shared across the care team, allowing for interventions at all high-value moments in care where failure points most commonly exist. So thinking about that more and thinking about it in practice, at Bamboo, we have done a lot to leverage our networks, particularly of our PINGs and PDMP solutions, to provide actionable intelligence at high-value moments in care, as can be seen from the two examples that are provided here on the screen. However, really want to emphasize that our work doesn't stop here. We still want to and need to do more. And as a care coordination organization, we at Bamboo are working to increase relevant social determinants of health and other information to better equip care team members. We are actively integrating behavioral health coordination needs into provider standard work, engaging directly with patients and their family and friends to help support their care journey, continuing to grow distribution and access to timely standard of care gaps that exist, and automating information sharing and documentation among all parties to ease the burden on providers and let them focus on the patient and not on managing a system. So with all of this in mind, how is interoperability likely to evolve over time? And with ACO REACH, this will hopefully accelerate the drive for standardization and adoption of social determinants of health data and networks, as well as bringing additional attention to the importance of behavioral health information, access, and standards of care. And as we look ahead, the near and midterm focus really becomes on the evolution from foundational interoperability to actionable interoperability, and then ultimately to whole person care. And you can see here on the table on this current slide that we have some areas in which we've envisioned over the next 1 to 2 years, as well as over the next 3 to 5 years, where we and the industry at large can start to make strides moving towards that whole person care ultimate goal. So at the end of the day, the industry is continuing to trend toward an increase in value-based care models and an increase in interoperability, with each of the two further driving each other. And as a part of this, the work of providers really isn't changing fundamentally with ACO REACH. However, the incentives to treat high-risk patient populations are increasing, and this is core to what CMS has been trying to do with a number of their value-based care payment models. The emphasis on care coordination will definitely continue to be important for all patients, particularly those in high-risk populations, but the benefits may not be fully realizable without the help of actionable interoperability. All right. And this wraps up our presentation for today. And I know we only have a few minutes left, but would still love to be able to kick it back to Allison to open up the floor for any questions.
Thanks so much, Molly. Super helpful information. So for our attendees, if you have a question, you can put it in the question box, but I'll go ahead and kick things off. So Molly, I am curious your thoughts about how specifically you think the REACH model is going to help advance that actionable interoperability that you were talking about.
Yeah, absolutely. I think when it comes down to it at the end of the day, one of the benefits of the ACO REACH model really is that focus on SDOH, or social determinants of health, and behavioral health. And I think and hope that the ACO REACH models incentives to, support more high needs populations and the inclusion of broader types of care team members over time will really drive awareness around what providers need to help these higher risk populations, and ultimately, drive industry standards that kind of help move along our shift from that foundational interoperability of just, having connectivity to actual interoperability and actionable interoperability that will help providers best serve the higher risk populations that these models focus in on.
Awesome, thanks. So we heard a lot about the benefits of moving towards actionable interoperability, but what big hurdles do you think are still in the way that are preventing us from, realizing those aspirations of actionable interoperability?
Oh, totally. And I think, in thinking of this, it's helpful to kind of think back to, even in the initial shift towards interoperability and data exchange over the past, 10, 15 years now. I think a lot of the ways in which we've seen kind of a stagnation of the shift to additional interoperability and ultimately in our minds to actionable interoperability comes down to things like the cost, complexity when different organizations are required to take on new data connections and standards. Speaking of standards, just the lack of standard adoption across the healthcare kind of universe. And then beyond that, I'd say, just the normal pace of innovation. It takes time to get things like this adopted, and there needs to be a clear sense of ROI and incentives for organizations to be able to take that leap and that risk to move into a more interoperable world.
Awesome. And kind of one final question for you, because I know we're at time. There's a lot of talk, about how we can better support people with their behavioral health needs. And in July, 988, the behavioral health version of 911, officially launches. How do you see this new REACH model fitting into some of those efforts to take a better look at behavioral health broadly?
Yeah, so I'd say, first of all, very excited about, which sounds geeky to say, but the launch of 988. I think it is so important for our healthcare communities at large. And I'd say between 988 and the ACO REACH model, it really has just become apparent and widely accepted that mental and physical health are inextricably linked, and that mental health is even more heavily impacted by many social and economic factors than previously thought. And so I think it's exciting that ACO REACH aims to focus attention on some of these factors and the populations, because at the end of the day, mental health and behavioral health feed directly into physical health and vice versa. And so being able to have programs in place that both drive awareness as well as actually give providers and other, members of the healthcare community the tools they need to help address some of the problems with these populations is super exciting and hopefully will be a big step forward.
Well, thank you so much, Molly, today for your time and expertise today. Just for the audience, you're welcome to email any additional questions to solutions@bamboohealth.com, and you will receive a follow-up email from us with a recording that we'd love if you want to share with your colleagues, your peers, anyone you think might be interested. We would appreciate it, and thanks so much for attending.
Awesome. Thank you, everyone.